Welcome to the deep dive. We're here to sift through, all sorts of sources, articles, research, notes, basically digging out the most vital bits of knowledge, the key insights, and yeah, sometimes the really surprising stuff too. All for you. Today, we are diving deep into a really critical area, men's genitourinary health.
Yeah, absolutely critical.
Our mission really is to cut through all the complex medical talk and give you the practical need-to-know info so you can get up to speed quickly on conditions affecting, the prostate, scrotum, penis, and erectile function.
And what's really fascinating here is just how common these conditions are. They affect so many men,
Mm.
all different ages, but often they just don't get talked about.
Right.
And this isn't just about knowing medical terms. It's really about empowerment, isn't it?
Yeah,
Being able to spot those crucial signs early, maybe for yourself, maybe for someone you care about.
exactly.
So this deep dive, hopefully, will bring some clarity, highlight some important differences that honestly can make a huge difference in how you navigate these health challenges, sometimes in ways you wouldn't expect.
Absolutely. So, okay, let's start with the prostate. It's an organ that definitely becomes more prominent as men age. To kick us off, let's picture a scenario, one we see a lot. Maybe a 60-year-old guy, he's noticing changes, needing to go more often, maybe some trouble starting, that kind of annoying dribble afterwards.
Classic symptoms.
These symptoms, especially at that age, they really make you think of benign prostatic hyperplasia or BPH. So how would you define BPH for us?
Okay, so BPH is basically a non-cancerous enlargement of the prostate gland. It's not malignant, but it grows, and it can squeeze the urethra. The tube urine passes through, and that squeezing causes those lower urinary tract symptoms you just mentioned. And yeah, while it's benign, it can really impact the man's quality of life significantly.
Right, like the plumbing's getting pinched. So when a doctor does an exam, specifically the digital rectal exam, the DRE, what do they usually feel for BPH? Is there like a handy way to remember it?
There is actually, it's quite memorable. Big, puffy, happy. On the DRE, the prostate typically feels enlarged, yeah. But it's symmetrical, smooth, and has this sort of rubbery feel. Big, puffy, happy equals benign prostatic hyperplasia.
Nice mnemonic.
What's interesting, physiologically speaking, is that as men get older, this hormone, dihydrotestosterone or DHT, it kind of accumulates in the prostate cells. Now, that's normal, but it drives this hyperplasia, basically. More cells grow, which makes the gland bigger, compresses the urethra, and bingo, you get those urinary symptoms.
Ah, so it's not just getting older, it's a specific hormonal thing happening. How do we manage it then? What are the usual approaches?
Well, we got some pretty good options. Medications like alpha blockers, you might have heard of terazosin, doxazosin, tamsulosin. They work by relaxing the muscles in the prostate and the bladder neck. Makes it easier for urine to flow.
Okay.
Then there are 5-alpha reductase inhibitors. Finasteride is a common one. These actually work differently. They shrink the prostate over time by blocking the conversion of testosterone to that DHT we mentioned.
Right, tackling the hormone directly.
Exactly. And, you also hear about the herbal supplement, saw palmetto. It comes up a lot, though. The evidence for how well it works is still a bit debated.
Good to know. And it's important to manage BPH, right? Because if you just leave it, what can happen? What are the complications?
Yeah, definitely don't want to ignore it. Untreated BPH can lead to some serious problems, like acute urinary retention, where you suddenly can't pee at all.
Wow, okay.
Also, recurrent urinary tract infections, bladder stones, and in really bad, prolonged cases, it could even cause kidney damage because of the back pressure.
Okay, serious stuff. Now let's tweak that scenario. What if our 60-year-old patient's symptoms suddenly got way worse? Like, bam, high fever, chills, body aches, on top of the urinary trouble. That sounds different. Maybe more like acute bacterial prostatitis.
That's a perfect pivot because it really highlights the difference between that chronic enlargement, BPH, and an acute infection. Acute bacterial prostatitis is exactly that, an infection and inflammation of the prostate gland. And unlike BPH, which usually creeps up slowly, this often hits suddenly with pretty severe symptoms.
And what are those key symptoms, besides the fever and chills?
You typically see a really dramatic increase in urinary urgency, gotta go now, and frequency, going all the time. Plus, painful urination, we call that dysuria. And yeah, those systemic flu-like feelings are very common too.
And the DRE, how would that feel compared to BPH?
Oh, completely different. With acute prostatitis, the prostate would likely feel acutely warm to the touch, extremely tender-like, really painful for the patient, and kind of boggy or swollen. It's a very different texture.
Wow, so diagnosis mainly relies on.
Primarily the urine gram stain and culture. We need to identify the specific bacteria causing the trouble.
Okay. And treatment, especially thinking about different potential causes.
For treatment, we usually start with broad-spectrum antibiotics. Ciprofloxacin, levofloxacin, trimethoprim, sulfamethoxazole are common choices. But, and this is really important, if the patient is sexually active and under 35, or maybe older but has high-risk sexual behaviors, we absolutely have to think about sexually transmitted infections causing it.
Ah, right, like chlamydia or gonorrhea.
Exactly. In those cases, the antibiotic plan needs to cover those bugs too, often using something like ceftriaxone plus doxycycline.
That's a crucial distinction for treatment. And if acute prostatitis isn't treated properly, what are the risks?
It can get quite serious. There's potential for a prostate abscess to form, or even sepsis if the infection spreads into the bloodstream. Definitely needs effective treatment.
Okay, moving on to another major prostate concern, prostate cancer. How does this typically show up and what makes it, such a silent threat often?
Yeah, the key thing about prostate cancer, especially early on, is that it's often completely asymptomatic. No symptoms at all. Which means men can have it growing without knowing it. And that's why screening becomes such a big and sometimes complicated discussion. It's most common in men over 65.
So back to our 60-year-old patient. If he had prostate cancer instead of DPH or prostatitis, what would that DRE feel like? What's the specific finding that raises a red flag for cancer?
That's a great question because the feel is really distinct for each condition. With prostate cancer, the classic finding on DRE is a firm, thick, painless nodule or a hardened area. It's a very different sensation from the smooth, rubbery feel of BPH or that super tender, boggy feel of acute prostatitis. That firmness, that hardness is the key.
Firm, thick, painless nodule. Got it. And how do we screen for this silent threat then?
Screening primarily involves the PSA blood test, prostate-specific antigen. But this is where the conversation gets a bit more nuanced. Major groups like the USPSTF, the U.S. Preventive Services Task Force, they recommend shared decision-making about PSA screening for men aged 55 to 69.
Shared decision-making. Why is that approach emphasized?
Well, because PSA screening isn't perfect. A high PSA can lead to anxiety, further tests like biopsies, which have their own risks, infection, bleeding, and crucially, it can lead to overdiagnosis, finding cancers that might be slow-growing and might never have actually caused any harm in a man's lifetime. Treating those cancers can lead to side effects like incontinence or erectile dysfunction.
Ah, so it's a balance.
Exactly. It's about weighing the potential benefit of catching aggressive cancer early against the potential harms of screening and overtreatment for that specific individual, considering their health, their values, everything. That's why the discussion with the doctor is so vital.
Really highlights the importance of that conversation. Okay, so if prostate cancer is suspected based on DRE or PSA,
then referral to a urologist is the standard next step. They'll manage the further workup and treatment plan. And unfortunately, if it's missed or found late, complications can include metastasis, the cancer spreading, and ultimately, it can be fatal.
So just to recap that key DRE takeaway.
Yes. For BPH, think enlarged, symmetrical, rubbery, big, puffy, happy. For acute prostatitis, warm, very tender, boggy, swollen. And for prostate cancer, that firm, thick, often painless nodule. Knowing those differences is huge.
Powerful distinctions. Okay, let's shift gears, move south a bit to scrotal conditions. These can range from, pretty harmless fluid issues to absolute emergencies needing immediate attention. First one, hydrocele. What's that?
A hydrocele is basically a collection of fluid around the testicle inside the scrotum. It shows up as a painless swelling. Sometimes the skin might get a bit irritated from the swelling, but pain isn't the main feature.
Okay, painless swelling. How do docs diagnose it? Is there a neat trick?
Yeah, there is. It's called transelimination. You shine a bright light through the swollen part of the scrotum. If it's just fluid, like in a hydrocele, the light passes right through and the whole area kind of glows. If it were a solid mass, the light wouldn't pass through like that.
Cool test, like shining a light through a water bottle versus a rock.
Exactly. Perfect analogy.
And I understand most hydroceles, especially in babies, just go away on their own. When would you need to see a specialist?
That's right. They often resolve spontaneously. But if an infant still has a hydrocele by the time they turn 1 year old, then a referral to a pediatric urologist is usually recommended, just to make sure nothing else is going on.
Got it. Then there's varicocele. Sounds different. What's the story there?
Varicocele is different. It's basically enlarged veins within the scrotum, think varicose veins, but in the scrotum. On exam, it often feels like a bag of worms along the spermatic cord. It's a very distinct feeling when you palpate it. Usually they don't cause pain, they're asymptomatic, but some guys might feel a kind of dull ache or heaviness.
Bagworms. Okay, memorable. So the physical exam is usually key.
Primarily, yes. Though an ultrasound can confirm it and see how extensive it is, usually management is just observation, conservative, unless it's causing significant symptoms or other issues.
Like what kind of issues? When would a referral be needed?
The main reason for referral, beyond bad symptoms, is concern about fertility. Varicoceles can sometimes affect sperm count or sperm motility, potentially leading to infertility. So if that's a concern, definitely see a urologist.
Right, fertility implications. Okay, next up, epididymal cysts or spermatoceles. What are those about?
These are also pretty common benign lumps. They're painless, fluid-filled sacs that form in the epididymis, that coiled tube behind the testicle where sperm matures and is stored. If the cyst gets bigger, say over 2 centimeters, we usually call it a spermatocele. But it's essentially the same kind of thing.
And diagnosis, similar to hydroceles again.
Yep, they often transilluminate like hydroceles because they're fluid-filled. An ultrasound can confirm it too. Generally, they don't need any treatment unless they become large enough to cause discomfort. Then a referral might be considered.
We've talked a lot about inflammation. What about when the testicle itself gets inflamed? What's orchitis?
Orchitis is inflammation of the testicle itself. It can be caused by viruses. Mumps is a classic example, even years after having mumps as a kid, or bacteria. It usually shows up on one side, causing scrotal pain, discomfort, and swelling. An ultrasound helps confirm it's orchitis.
And how is it treated?
Management is mostly supportive rest pain relief. If it seems related to epididymitis, which is inflammation of that epididymis tube we mentioned, then we treat it like epididymitis. One important point about orchitis, especially if it's caused by mumps, is that it can unfortunately sometimes lead to infertility later on.
Which leads us nicely to epididymitis itself, inflammation of that epididymis, unilateral testicular pain, swelling, and there's a really important clinical sign for this one, isn't there? The Prion sign. Can you explain that?
Yes, the Prion sign is super helpful. It's a physical exam finding. If you gently lift the affected scrotum and the pain gets better, that's a positive Prion sign.
Ah, lifting helps the pain.
Exactly. And that strongly suggests epididymitis. It's a key way to help differentiate it from other causes of acute scrotal pain, which is critical.
So not just pain, but pain that improves with elevation. How else is epididymitis diagnosed?
Diagnosis usually involves urine tests. A urine net, that's nucleic acid amplification test, plus a urine culture and urinalysis. We're specifically looking for bacteria, including gonorrhea and chlamydia, especially if an STI seems possible.
And the treatment depends on that STI risk, right?
Absolutely. If the risk of an STI is low, we might use an antibiotic like trimethoprim sulfamethoxazole Bactrim. It's a common brand name. But if there's a high risk of STI, or if the tests confirm gonorrhea or chlamydia, then the treatment needs to cover those. Typically, that means a combination, often ceftriaxone plus doxycycline.
And what are the risks if epididymitis isn't treated effectively?
Complications can include an abscess forming in the scrotum or potentially scarring that could lead to infertility, though that's less common.
Okay, now, shifting to something that is a true medical emergency, everyone listening needs to know about this. Testicular torsion. What is it, and why the extreme urgency?
Testicular torsion is sudden, it's severe, and it's incredibly painful. It happens when the spermatic cord, the structure that contains the blood vessels supplying the testicle, twists on itself.
Twists, cutting off blood flow.
Exactly. It cuts off the blood supply, and the clock starts ticking immediately. Without blood flow, the testicular tissue starts to die from lack of oxygen. That's ischemia. Permanent damage, even loss of the testicle, can happen within just a few hours. This is absolutely an emergency.
That thought alone is...
Yeah.
Yeah. Okay, so on exam, patient comes in with sudden, severe scrotal pain. What's the one finding that screams torsion?
The absolute classic critical finding is an absent cremasteric reflex.
Absent cremasteric reflex. Explain that.
Okay, normally if you gently stroke the inner part of the thigh, the testicle on that same side should pull upward slightly. That's the cremasteric reflex. In testicular torsion, because of the twisting and compromised nerve function, that reflex is usually gone. Absent. It's a massive red flag.
Wow. Okay. Any other tests?
A Doppler ultrasound is usually done urgently. It can show if there's blood flow getting to the testicle or not. No flow strongly supports torsion.
So bottom line for everyone listening, if you or someone you know experiences sudden, severe testicular pain, what is the single most important thing to do?
Get to the emergency department immediately. Do not wait. Do not hope he gets better. Time is tissue. Time is testicle. Immediate ED referral is paramount. This is definitely an on-the-test kind of scenario in medicine and critical for real life.
Couldn't be clearer. And this really highlights that crucial differential diagnosis, epididymitis versus testicular torsion. Can you quickly recap the key signs that help tell them apart?
Absolutely. Remember the pre-end sign. Pain gets better with elevation in epididymitis. That's usually not the case in torsion. Elevation often makes it worse or does nothing.
Yeah.
And the big one, the cremasteric reflex. Usually present in epididymitis, but absent in torsion. So rule number one with acute scrotal pain, check that reflex. If it's absent, assume torsion until proven otherwise and get that patient to surgery fast.
Because the complication...
Loss of the testicle. Permanent loss if blood flow isn't restored quickly.
Okay, one more scrotal condition. Testicular cancer. Who typically gets this, and how does it usually present?
Testicular cancer, interestingly, is most common in younger men. Think ages 15 to 35, primarily, although it can happen at any age. And the typical presentation is a firm, painless lump or mass on the testicle itself. Unlike torsion or epididymitis, pain is usually not the main feature, especially early on.
Painless lump in a younger man. Red flag. How's it diagnosed and managed?
Diagnosis starts with a physical exam, feeling that lump, followed by a scrotal ultrasound to confirm it's a solid mass. Then it's always a referral to urology. The good news, though, is that testicular cancer, when caught early, has a very, very high cure rate, which is why self-exams and seeing a doctor for any new lump are so important.
Absolutely vital message. Okay, let's move up now to conditions affecting the penis itself, starting with balanitis. What is that, and what usually causes it?
Balanitis is basically inflammation and an irritation of the glands, the head of the penis. It's often linked to hygiene, especially in uncircumcised men, if the foreskin isn't pulled back and cleaned properly.
Makes sense. What are the symptoms like?
Usually pain, redness, maybe some swelling, and often there's a discharge, sometimes white and maybe foul-smelling. A common culprit, especially if there's discharge, is candidiasis, a yeast infection, particularly common in men with diabetes.
So hygiene is key for management.
Absolutely paramount. Good hygiene often resolves mild cases. If it's yeast, an antifungal cream is needed. If it keeps happening or doesn't clear up, potential complications include phimosis, where the foreskin gets too tight to retract, or worsening infection.
Okay, then there's Peyronie's disease. That sound painful and potentially quite distressing. What is it?
Peyronie's disease is where fibrous scar tissue, or plaques, build up inside the penis. This causes the erection to become curved, and it's often painful, especially during the erection. It can develop over time, and the bend can sometimes be quite significant.
How is that managed? And what's the main worry?
Management starts with a thorough history and exam to really understand the curvature and pain. If Peyronie's is suspected, a referral to urology is definitely needed. There's various treatment options. The main complication, apart from the pain and the curve itself, is often erectile dysfunction. The scar tissue can interfere with the mechanics of getting and keeping an erection.
Right, makes sense. Another urgent one, ischemic priapism. What defines this, and why is it an emergency?
Okay, ischemic priapism is a prolonged erection, lasting 4 hours or more, that is not related to sexual stimulation or desire. And it's usually painful. It's an emergency because the blood trapped in the penis isn't circulating properly. It becomes deoxygenated, low in oxygen. This lack of oxygen can damage the erectile tissues.
Any conditions commonly linked to it?
It has a known association with sickle cell disease. It could also be a side effect of certain medications, including some ED drugs or antidepressants.
So history and exam are important.
Very. But the absolute key message here, again, we cannot stress this enough. If someone has an erection lasting 4 hours or more, especially if it's painful, they need immediate evaluation in an emergency department. Waiting risks permanent damage to the penis. Don't delay.
Urgent message received. Okay, finally, let's address erectile dysfunction, ED. It's common, but often difficult to talk about.
Yeah, ED is defined as the consistent difficulty in achieving or maintaining an erection that's firm enough for sexual intercourse. And what's really crucial to get across is that it's usually not just one single thing causing it. It can be vascular problems with blood flow, neurologic nerve issues, psychological factors like stress or anxiety, or hormonal like low testosterone. Investigating the underlying cause is so important because sometimes ED can be the first sign of another health problem, like heart disease or diabetes.
That's a really important point. And what about management strategies?
Often starts with lifestyle changes. Things like improving diet, getting more exercise, quitting smoking, managing stress. These can make a big difference. Then there's pharmacotherapy, medications. The most well-known are the phosphodiesterase type 5 inhibitors, the PDE5 inhibitors. Sildenafil Viagra is the famous one, but there are others like tadalafil, Cialis, and vardenafil, Levitra.
And it seems really important to handle this topic sensitively, right? For both doctors and patients.
Absolutely. For healthcare providers, it requires offering compassionate, non-judgmental care, creating a safe space for men to talk about it. And for patients, feeling comfortable enough to bring it up is key, because ED can have a really significant psychosocial impact, affecting relationships, self-confidence, quality of life.
That psychosocial piece is huge, definitely a real complication we need to acknowledge.
Empathy and understanding are critical.
Okay, wow. We have really unpacked a lot today. We've covered a huge amount of ground in men's genitourinary health. From common prostate issues like BPH to infections like prostatitis, the seriousness of prostate cancer, then down to the scrotum hydroceles, varicoceles, cysts, the inflammations of erectile and epididymitis, the emergency of torsion and testicular cancer, then penile issues like balanitis, Peyronie's, the urgency of priapism, and finally, tackling erectile dysfunction.
Quite the tour.
Yeah. So the value here is that you, listening, now have a much better handle on the key terms, the symptoms to watch for, those vital diagnostic clues like remembering the pre and sign for epididymitis, or that absent cremasteric reflex really pointing towards torsion, and the basic approaches to management. This knowledge is empowering.
It really is. And, this raises an important question for you, the listener, to maybe think about after this deep dive. As you've taken in all this information about these different conditions, their signs, their implications, how might really understanding these things change how you approach your own health or encourage the men in your life to approach theirs? How can knowing these distinctions, knowing the red flags, maybe make those conversations with healthcare providers a bit less intimidating, a bit more effective? Because ultimately that knowledge is the power to advocate for yourself and ensure you get timely, appropriate care. Something to reflect on.